All right. Welcome, everybody, to our Ask the Experts webinar session. Dr. John Santana. I'm here with Dr. Tom Nabity. Together, we're in the Michigan Center for Regenerative Medicine. So we kind of wanted to change up the format of our webinar. This time, instead of us just doing a presentation, we actually took questions from you guys. And we're going to try and read these questions out to you and kind of answer them. So hopefully it'll be more educational for everyone. And let's get going. So I'll go ahead and start. So this question is for Dr. Tom Nabity. So the question is, what is regenerative medicine and how long has it been around?
Okay, so a nice broad question to start. Regenerative medicine is a very global, non-specific term. It means anything that would stimulate growth and healing in the body. So me personally, I use that term loosely to describe not just the regenerative injections that we do here, but things that are also regenerative to the body, like eating well, exercising, taking supplements, which are things that I think both Dr. Sand and I pride ourselves on when we talk to patients and when we review a case or we review some sort of an illness, that we really not just focus on what can we do with a needle and what can we do with like stem cells or platelet-rich plasma, but also what can we do with them as a complete human. What sorts of other activities or what sort of other avenues can we also improve their regenerative capabilities in their body. But specifically to what our skill set is, what our niche within that regenerative space is, the three things that I we specialize in from a regenerative injection standpoint are prolotherapy, platelet-rich plasma, and stem cell therapy, which, looking at some of the other questions we have, I know we'll get into more details as those questions come up. So I think I'll, my time is up. I think we probably have to have a timer on this. Probably up to answer that question, but regenerative medicine is not just the things we can do through the needle. And both Dr. Santana and I really pride ourselves on looking at everything that's regenerative, not just the injection.
That's true. And just going to add on to what Dr. Nabity is saying is that it's not just regenerative medicine doesn't stop and start here in our clinic. It's a lifestyle choice that patients will make before coming into the office and seeing us, and then after they leave the office and after they've gotten better from the procedure. So it's something that it's important for everyone.
All right, so Dr. Santana are going to kind of just rally back and forth with the questions. So I got the next question on the list here. It's from patient Frank in Southfield. Frank asks, he has a rotator cuff issue. It's been going on for years. He's had physical therapy. He's tried cortisone injections. He's been offered a rotator cuff repair, and he's been reading about prolotherapy and is wondering if that would benefit him. And I'll add in that question my own thing. What other regenerative injections, Dr. Santa, and it might help someone with a rotator cuff issue who's failed conservative treatment?
Great question, Frank. So we see a lot of rotator cuff issues here, mainly because it's one of these injuries that people sustain when they do sports-related type activities and things like that, or it could just be from degeneration as well. So when we talk about regenerative medicine, we typically talk about three things. So it's either prolotherapy, platelet-rich plasma, or bone marrow stem cells. So prolotherapy is the earliest form of regenerative medicine procedure that's been around. The idea with that is we're using an external stimulant, something like sugar water, and we inject it into the tendons of the rotator cuff in the shoulder to start an inflammatory response. So the inflammatory response is what you need to start the healing process. So prolotherapy kind of starts that healing process. The problem with prolotherapy is that of the three types of regenerative medicine treatments that we do, it's probably the weakest one. So we typically do a procedure like this with injecting the the tendon with prolotherapy and around that joint, a few times, like 4 or 5 times, depending on what we're trying to accomplish. So maybe it's definitely not convenient because you have to keep returning back to the office every few days or a few weeks to kind of get another treatment. PRP is platelet-rich plasma. That's the other option for rotator cuff tears. I tend to gravitate more towards PRP with tendon type issues, not weight-bearing joints. Do you agree, Dr. Nabity? That's kind of like where we find PRP in. If it's something like a rotator cuff tear would respond really well to PRP or platelet-rich plasma. For more severe type conditions, let's say it's a weight-bearing joint or we're talking about a complete tear of the rotator cuff, depending on what we see on imaging and on the exam, somebody might qualify to have a bone marrow stem cell procedure instead if we're trying to heal a bigger structure or a bigger defect. Now, when we do our evaluations for rotator cuffs, we have criteria that we look for as far as what makes somebody a good candidate for it. So we kind of do our due diligence as far as guiding people on the right treatment option for them when they come through the clinic. Good question. So I guess like just to piggyback on that question, Dr. Nabity, how do you, when you counsel your patients when they come in, how do you determine whether somebody needs, prolotherapy, PRP, or bone marrow? And is it site specific, injury specific? How do you do that?
Yeah, great question. It's not a one size fits all. There's not a recipe book that we've developed yet. Combination of severity of illness. So if I had to summarize the difference between prolotherapy, PRP, and stem cells in one word, I would say that word is potency. So they all stimulate a growth and healing response, but just to a different potency level. So just if you think about these injections being like a drug, sometimes 200 milligrams of Motrin's enough, but sometimes you need 800 milligrams. So it depends on how strong of a dose we think we need. So if you're starting from a lower starting point, your arthritis is more severe, your tear is more severe, we might need that bone marrow stem cell procedure. Whereas if it's a very minor tendinosis or tendonitis problem, we may be able to get away with prolotherapy. So severity makes a difference. Age and potency or quality of the stem cells makes a difference, or regenerative procedure makes a difference. The last, I guess, bit that I would say that I determine that is patient's activity level, like what do they want to get back to? Are they looking to get back to very competitive kind of training and exercise? Are they looking to get back more to just like activities of daily living, being able to walk with less pain, being able to sleep without pain? What's the patient's goal level?
Yep. Kind of same. So I kind of follow the same algorithm. Again, we kind of look at the symptoms and also what their goals are. Okay.
Got a question typed in here from Chris, and I think this is a good one I'd like to add into our list. What exactly did you folks move to treating patients with regenerative medicine? So I don't know if you want to talk a little bit about our backgrounds as pain doctors, and then what drove us to regenerative medicine. Yeah.
So like Dr. Nabity said, we're classically trained, board certified physical medicine and rehabilitation physicians. We specialize in sports and spine medicine. We started our careers as interventional pain physicians. So we would see a lot of patients coming into the office with complaints of back pain, shoulder pain, knee pain, joint pain, stuff like that. And we would do our treatments, we'll do our evaluations. A lot of times, the way that traditional medicine treats these type of conditions, you go through a round where you do physical therapy, and then if that doesn't help, you can prescribe some medications. If that doesn't help, you can try doing some injections, and then there's some minimally invasive type procedures that we could do to relieve pains. We could do nerve blocks, we could do steroid injections, we could do nerve stimulators, and if none of that works, then we usually tell the patients that you need to see a surgeon, and at that point, you get a surgical consultation on whether you get a joint replacement or a fusion or something like that. So that's kind of been what we've been seeing in traditional medicine. It's not ideal, but it's kind of the process that we have. So when Dr. Nabity, well, speaking for myself, when I started learning more about regenerative medicine and how we can actually exploit the body's ability to heal. So instead of using something like a steroid or an anti-inflammatory like a Motrin or an Aleve to stop the inflammation and the healing process, if we're able to actually stimulate your body to heal itself by using your cells and your platelets so that it would heal more naturally, then that's when we started seeing really significant outcomes from our patient when they're able to kind of return to the things that they like to do, just perform normal activities. And it's been a really eye-opening experience for me, as far as rather than just treating the symptoms and kind of putting a Band-Aid on something that it's not healing, to actually turning the paradigm and actually healing the source of the problem. That just made it for me, that made me decide that this is the right area of medicine I want to be in.
Yeah, I echo that sentiment from frustration with the pain management options when we aren't able to get people back to their the quality of life that they're looking for, and especially those that we've seen that have then had surgery and still have their problem, especially with the spine. A couple patients come to mind. The first person we treated was a friend of both Dr. Santana and I's, and he had a spine issue that was preventing him from being able to do his physical function testing in his career as a Air Force Reserve. He was looking at either taking a medical discharge or having a 2-level fusion, were the two options he was given through the Air Force. And he asked us if we'd be willing to give for him a PRP injection to try, and we did that for him. And within 6 months, he was able to get back to all his testing. He was able to carry a 70-pound rucksack and do the running that he had to do in order to stay in the active reserves. And that for me was a real eye-opening moment where, wow, there's a lot of people I'm not helping that I could be. And there's a lot of surgeries we could be preventing that we're just not doing it because we're not offering it to enough people. So that was one of the reasons that really motivated me to get more involved in getting this out there and getting over some of those roadblocks and those hurdles that are keeping it from becoming more mainstream. And that's one of our passions here. One of our mission statements here is to contribute to the field such that it does become standard of care. There's a lot of obstacles. We're not here to tell you and complain to you about the obstacles that we have, but we are here to tell you this is an option and it works. Nothing in medicine is 100%, but it works vast majority of the time. I put it, depending on the condition, anywhere from 70 to 90% of patients we treat get successful outcomes.
Yeah. So should we change gears a little bit? We're getting a lot of really good questions on the chat board here. Maybe we kind of switch gears a little bit. So let's take the question from Joanne. It says, I had stem cell injections done on my knee 3 years ago. My knees are worse now than they ever were. I also had a booster done 2 years ago. I'd had torn the meniscus in both knees. Does it take this long to heal?
So no, to answer your last question there first, it does not take this long to heal. That is outside the normal healing timeline. The normal healing timeline, it starts at about 6 weeks, and then it completes its healing at about 6 months. So the benefit you should get should be within the first 6 months. Now, I'll say I've had patients take up to a year to get their full benefit, but they've all noticed something at least by 3 months. So the fact that it's been 3 years for you is far outside the room. That's not taking that long to heal. I don't know if you had your procedure done with us or not. If it was with us, I certainly apologize that it's not working for you. Like I said, it doesn't work 100% of the time. We're darn good at our outcomes, but I'm not going to tell you we're 100%. If it was done somewhere else, I would question what was actually injected. There's a lot of misinformation out there about stem cells, which is really what Dr. Sand and I's passion or interest in doing these webinars is to try to spread more education, proper education about the types of stem cell therapies that have a good chance at working. And the types that work really need to come from you. They're autologous stem cells coming from your own body, not the donor stem cells. So if somebody told you they injected you with an umbilical cord stem cell or someone else's stem cell, I can tell you they're either doing something illegal, or they don't know what's in their needle, or they're just lying. Right now, it's illegal to use any kind of donor stem cell in the United States for anything other than a bone marrow transplant. So if they're telling you they're doing a donor stem cell injection, they're either doing something illegal, or they don't know what's in their syringe. We've had plenty of reps come and try to sell us amniotic fluid, which is the fluid that surrounds the baby, but not the umbilical cord cells. And there's been plenty of testing in that fluid. The freeze thaw process that's required in order to store that fluid properly, which is legal, kills any and all cells that are in it. So it's a completely acellular injection. There are some growth factors. There are some positive things that could help people with knee pain, but it's not a stem cell procedure. So that's a key thing to know. And the stuff's extremely expensive. It's cost prohibitive for us to use that compared to the good quality stem cells we can produce in our own lab here. So for me, I haven't found a patient where I feel like it's the right decision for them. I'm not opposed 100% to using it, but it's just not something I use on a regular basis. So just back to your question, we would love to do an actual consult with you. Even if you are our patient, we would love to have you follow up, take another look, and maybe there's some other things we can offer you. Some of the things that Dr. Santa Anna alluded to that are within our pain management skill set, like these peripheral nerve stimulators that are coming out that are really beneficial for joint pains by stimulating the nerve that comes to the joint pain, give you something other than a knee replacement as an option so you don't have to live in pain.
And I just want to add to that. I think that's one of the bigger advantages that we have with our background in pain management and sports and spine medicine is that we're able to have a pretty big toolbox when it comes to treating patients. So it may not be a good candidate for stem cells or one or the other, but there's always something that we can offer you that can help with pain or your function.
Let's do the next question. I think this is a good one too.
Yeah.
It kind of sets us apart from a lot of the medicine you and I have practiced in the past. What is a typical first visit from Michelle?
Good question, Michelle. So typically when you come into a first visit, we do a pretty comprehensive evaluation. So even though stem cells and regenerative medicine is not covered by insurance, we still approach it in a very medical and methodical way. So a lot of times when we talk to patients, I want to kind of get a good history, background on the injury, how long they've had the problem for, do they have any other medical conditions, what makes it better, what makes it worse. So typical types of visit that you would get when you see an orthopedic surgeon or a specialist. After that, I do like seeing images. So if you have an MRI or an X-ray that you can bring to the appointment, I usually go over that with you so that you and I both understand kind of what we're dealing with, what structures need to be addressed, what's causing all the pain and dysfunction. After that, we do a pretty comprehensive physical examination, primarily directed towards the site that we're addressing. After that, depending on what we're seeing and depending if you have imaging or not, we can even pull in an ultrasound that we have here in the office or an X-ray. And what we do is we can take a look at how your joints are functioning real time on the ultrasound. Then we can kind of get a better idea of kind of what areas to treat and how to proceed with the treatment plan. After that, we go over the process of what's regenerative medicine, what type of regenerative medicine treatments we could recommend, whether it's prolotherapy or PRP versus bone marrow stem cells. Then from there, we kind of decide what's going to be the best treatment plan for you, which structures we need to address, what's the recovery time, what's the pain like, what's the process going to be like, when are you going to get better, when can you start physical therapy. So all of these questions that you have specifically to your case, we go over that. Typically, our appointments for visits are about an hour because we really want to dive deep into what's going on and get to the root cause of the problem so we can get the best treatment for you. Sometimes we do a follow-up consultation. If you order more testing or imaging or something like that, then we have you follow up again and we go over that so that you and I will know exactly what the plan is and what to expect.
Yeah, I'll just add, I guess the comment we get is more times than not is, wow, I've never had a doctor spend this much time with me. It typically takes about at least 45 minutes to an hour, depending on the significance of the history, how much of an exam we need to do, how much ultrasound imaging we need to do. But it's a lengthy exam. And while if we decide that a stem cell or regenerative medicine procedure is right for you, that might not be covered by insurance. Your exam, your consultation is, and we'll talk about the other things that your insurance could cover as well that you might benefit from. So we do try to utilize insurance when possible, when it's the right choice. And we certainly have those discussions as well. It's not hey, we do stem cells and that's it. If you can't benefit from stem cells, don't bother coming in. That's not our style. That's not our practice. We're here to work with our patients and come up with a plan that'll work for them.
Yeah. Here's another good question. This one's from Valerie. Why is that orthopedic surgeons say it doesn't work? What is success rate for a patient over 60 with torn meniscus with arthritis present?
Yeah, great question. The first part, not all orthopedic surgeons don't say it works. It certainly is more skeptical in their field than the regenerative medicine field. Folks like Dr. Santana and I who have come over to the regenerative medicine side. But I do have orthopedic colleagues of mine that are starting to incorporate this into what they're doing. Certainly the more early adapters are incorporated into their practices, the sports medicine doctors. I had a call last week with a sports medicine doctor in Los Angeles who's incorporated it into her practice. She did a dedicated fellowship on regenerative medicine through orthopedics. There's the Andrews Institute in South Florida. That's an orthopedic-based practice that's training orthopedic surgeons to incorporate this into their practice. The American Academy of Orthopedic Surgeons, the AAOS, has made a position statement last year that we need to start incorporating regenerative medicine training and regenerative medicine studies into our practice. So it's not that they don't believe it doesn't work, and it's not like all doctors believe it does or doesn't work. There are definitely need to be more studies, and it is something we are actively participating in at our clinic at the Michigan Center of Regenerative Medicine. And I will say the number one thing that's important for us to move this science forward, this regenerative medicine science forward, is that we start to give our regenerative medicine procedures a dose, which means we need to count the cells. Not all PRP is the same. Not all stem cells are the same. If I inject you with 100,000 platelets per microliter versus 1.1 million platelets per microliter, do you think there's going to be a difference? Yes, there's a difference. There's a difference in the dose. Just like if I injected you with 1 milligram of Depomedrol or 80 milligrams of Depomedrol, there's probably going to be a difference because there's a huge difference in the dose. So that's the number one thing that the regenerative medicine space just has not done a good job of. Everybody who does PRP says they do PRP, but if you ask them what's in their syringe, they can't tell you because they're not counting. We do that here at our clinic. We count the cells. We know exactly how much platelets you're getting, how many total nucleated stem cells you're getting, so we can give you a reassurance that you're getting an appropriate amount of cells. Second question, what's the success rate for patients 60 years old with a torn meniscus and arthritis present? Would want to examine you. If it's just your torn meniscus, platelet-rich plasma works great for that. 90% of the time, excellent outcomes with meniscus. Arthritis in the joint, then we're going to get into how severe yours is. If it's on the more severe side, we're going to recommend a bone marrow procedure in order to get to that 80% outcome. If it's on the more mild side with the arthritis, platelet-rich plasma is likely going to be all you need. One of the other things we're evaluating is whether there's additional substances in what's called the platelet-poor plasma that can be helpful in adding those back in. So that's a study we're in the process of designing and hopefully have implemented soon, so that we can really try to figure out what is the absolute best regenerative substance to be injecting our patients with.
Yep. By the way, just for the orthopedic surgeon, so the current president-elect is of the Interventional Orthobiologics Foundation is a orthopedic surgeon.
Yeah, that's a great point. Yeah, so the society Dr. Santana and I are most active in, our future president for next year is an orthopedic surgeon. So they do believe in it. There are orthopedic surgeons that believe in it, and it will come into the mainstream. It's just a matter of how long.
Yeah, it's still pretty new. Still pretty new, so we're learning as we go. I want to say that Dr. Nabby and I I've definitely tried to do our best to be in front of the field. So we want to bring the latest and greatest technology and research here in Michigan.
I did one of the, back to one of the earlier questions, what made me get into this? One of the first conferences I went to, there was a keynote speaker by the name of Lenny Johnson, who was one of the first orthopedic surgeons in the 1970s to incorporate arthroscopic surgery into his practice. Well, at the time, that was brand new, and he lost his hospital privileges. He got thrown out of the American Academy of Orthopedic Surgeons, and people told him he was using the tool of the devil, and there's no way you can see with a scope what I can see when you do it open. Well, he knew what he was seeing. He knew the outcomes he was getting. He knew his patients were paying cash because they didn't want the downtime that came with the open procedure. They wanted to recover quicker, and a lot of more professional athletes whose careers depended on them getting back on the field quicker. And sure enough, over time, it showed that he was right. And he said, this is deja vu all over again. This is like me. This is how I felt when I was in the 70s. You gotta go with science. You got to document your outcomes. You got to document what you're injecting, and over time, it will come around. Everybody else will come around. But being an early adopter can be hard. You have to be steadfast. You have to be confident with what you're doing. And over time, it'll prove to be true.
Yeah.
I like Valerie's follow-up question to that. Risks, any chance of infection with this, Dr. Santana?
So like any other procedure where we go through the skin, either with an injection or with incision or anything like that, the chance for infection is the same, whether we're injecting you with a steroid versus injecting you with a gel versus injecting you with stem cells or PRP. The risk for infection is exactly the same. It all depends on the physician's skill as well as the technique. So in our training in medical school, that's hammered to every physician that how to do a surgically sterile technique, how to do a sterile injection. So the risk for infection for any type of injection is actually pretty low. It's around 0.1% of occurrence. So it's the chance that you're going to get infection is pretty low. The other advantage of bone marrow stem cells is that it has macrophages. So it actually is antibacterial in a sense, although we don't use that property of it that much. But again, this is more of a fun fact with stem cells.
And then other risks, I always talk to patients, improper needle placement or bad needle placement, which is why you want to go to someone who has skills in driving a needle, especially when you start talking about doing procedures on structures like the spine. So both Dr. Santana and I are board certified physical medicine rehabilitation specialists with subspecialty training in pain management. So we've dedicated our careers even pre being regenerative medicine specialists towards safely guiding needles into very specific areas in the body, whether that be your knee, your hip, your spine, using X-ray or ultrasound guidance. No matter how good he or I think I am, we can't see the needle tip once we puncture the skin. You have to use some sort of imaging in order to see through the skin. So in our clinic, that's X-ray and ultrasound. So the two main risks, infection and bad needle placement, that's how we mitigate those risks. The really great thing about regenerative medicine that's autologous, like what we use in our clinic, is you can't be allergic to it. It's your own cells. You can't reject it. Again, it's your own cells. So sticking with autologous when at all possible, your own cells, is the way to go. Again, one of the main reasons I don't use those amniotic fluid products, those allogenic donor products.
There's let's see, we're kind of running short on time, so I'm going to jump around with the questions here a little bit. Let's take this one from Janet. What is your feeling on exosome therapy?
Yeah,
that's a good one for you, Dr. Nabity.
Yeah, that's a good one. So exosomes, it's a hot topic in regenerative medicine right now. Certainly, exosomes are an acronym or a short for extracellular vesicles, ECVs. These extracellular vesicles, there's lots of different types of extracellular vesicles. That's the way our cells communicate with each other. So when one cell wants to send a signal to the cells that are around them, they push out mRNA, messenger mRNA, that tell that other cell what to do or how to regulate that other cell. Other things that are pushing out are things like trash and the things the cell needs to expel. But the things we're really interested in are those messenger mRNA vesicles. So one of the thoughts is, well, we don't really need the cells, we just need the signals those cells are creating, which is interesting and certainly just deserves more exploration. My personal view is it's more important than one ingredient. This is what we get when we do a PRP or a bone marrow procedure. When we take your blood out, when we spin it down in a centrifuge, when we isolate that middle layer, we're not just getting one thing. We're getting a whole soup of ingredients. And it's all of those ingredients in the soup that give it its flavor. There's not just one ingredient that's more important than the others. And the really enticing thing about exosomes is they don't have these HLA markers on them, which is a way that your body recognizes foreign invaders, so they don't mount an immune response. So theoretically, you could find a cell line and create these just like you could a drug, and then you could mass produce them and inject them in people and get some sort of a regenerative injection. I think that idea warrants evaluation. It has merit. I'm excited to see that sort of science take off, but where it's at right now, I just don't see it being as good as the PRP we have or as good as the bone marrow concentrate we have. What I am very interested in is you are isolating those exosomes from your own body. So now we're getting into the autologous exosomes or extracellular vesicles. And that's one of the products that we're evaluating. And we're working closely with a company called Forever Labs that has created a technique for being able to do that in a bedside centrifuge. Classically, the only way that you can isolate those exosomes from your own plasma is with these ultra high velocity centrifuges that are hundreds of thousands of dollars, not feasible in a community clinic. Places like Mayo Clinic and Cleveland Clinic can afford these sorts of devices, but they're just relegated for research. They're never going to hit the ground and be able to treat hundreds of thousands of people. Whereas this technique that Forever Labs has developed can isolate these autologous exosomes from the platelet-poor plasma from your blood or bone marrow that we just drew off. And it's something we can add back into your stem cell or to your platelet-rich plasma procedure to make it even better. So those are things that we're looking on. I'm very excited about exosomal therapy. I just don't think it's as a standalone therapy. I don't think it's the right choice for people yet. That definitely warrants further evaluation. The outcomes we're getting right now are too good for me to recommend something that in my head is still on the very early experimental phase. Yeah.
And plus you're getting, with the way that we process our PRP anyway, you are getting exosomes along with that injecting that we have. There yours.
Great. Kind of a tricky question. Is it Mariah or Mariah? I apologize if I mispronounced that, but why are these treatments not FDA approved?
Ooh, that's a tough question. So we have our own theories with it. So one of the things I think why it's not FDA approved, I'm sure there's a lot of reasons why, is that the FDA, the Food and Drug Administration, the way that they look at things that you inject, things that you put in patients is a drug. The problem with regenerative medicine and using your own autologous stem cells and autologous PRP is that you can't classify it as a drug because my stem cells and my PRP is going to be different from Dr. Nabity's. It's going to be different from yours, Mariah. So there's really no way for the FDA to kind of have some sort of a quantifiable number that they can assign to that ingredient. And I think that's not the only, but probably one of the hurdles that the FDA has, because up to this point, everything that we're doing in the medical field has some degree of quantitative number that the FDA has assigned to it. So that's one, and I'm sure there's other reasons for that as well, but I think that right now, from a from that point of view, I think it's one of the hurdles I see. What do you think is kind of blocking that too?
Yeah, and I think it's important to clarify exactly what does something mean to be FDA approved. So to me, that means that there's been a clinical trial, that it's proven to be beneficial, and that it has an indication for a specific disorder. That doesn't mean to say it's not FDA approved for us to be doing these procedures from a compliance standpoint. So the FDA does have rules around regenerative medicine, and there is what's called a same-day exclusion for physicians to do a procedure within the same day where you're taking out your cells, minimally manipulating them, and then putting them back into the same patient. So it's the same exclusion that's used for all sorts of tendon transfers and other things where we're taking skin grafts, where we're taking cells from one area of the body and putting them into another area of the body. There's a lot of benchmarks it has to pass, being what's called homologous use. So the same intended purpose within the body, the cells have to be used for. So I think it's an important thing for us to say tonight is that everything we do in our clinic is FDA approved. From that standpoint, it's all compliant. Let me say that back. Not FDA approved, but FDA compliant. Compliant with the FDA rules. So the fact that we don't have an indication for this yet it really speaks to the research and the science. Part of what we're working on, quantifying cells, tracking outcomes, proving that for specific indication it works, that's going to get FDA approval. But we are FDA compliant. Our lab is FDA compliant. It's been inspected and certified, and everything we do here at our clinic is within those same-day exceptions and the minimal manipulation clauses for FDA compliance. We have a lot more questions here. I don't know how much longer, and I don't think we've lost anybody yet, but I think our plan was to do about a half hour, maybe up to 45 minutes, and then just a brief tour of our facility tonight. So maybe we'll take a couple more. How about this one's kind of an easier one, but it does speak to the things that we offer here. Are you awake during the procedure?
So we most of our procedures that we do perform here in the clinic, people are awake. For the most part, when we treat joints such as shoulders or knees or ankles, things like that, we use what we call nitrous oxide sedation. So essentially, it's a nitrous oxide gas that gets you really, really relaxed to tolerate the procedure. It's the same type of sedation or procedure that you would get from your dentist when you have sort of a dental procedure done. It makes you really relaxed. We still do a local injection where we numb the area out that we're going to inject. So, but for the most part, the patient is awake. For more invasive type procedures, let's say we're going to do a spine or a disc or something along those lines, or if the patient has an aversion to needles or has had prior surgery in the joint where they are going to be really sensitive to the area that we're going to treat, we do offer IV anesthesia sedation. So it's the same type of sedation that you would get from an anesthesiologist when you receive a same-day procedure like a colonoscopy or something like that. So those we schedule those about once or twice a month for those kinds of things. But for the most part, we offer nitrous oxide sedation.
Yep, we use a lot of local anesthetic. You know, we see our target, we numb up the skin, we numb everything up. I've had plenty of these. Dr. Santana's injected me plenty of times. I think I've injected you once or twice. I know your ankle, but I can't remember if there's something else. But anyhow,
once I think once, still once.
Is it painful? Yes. Is it exquisite pain, unbearable pain? Absolutely not. I don't take any anesthesia when he does his. The only one where I really encourage it is the spine. The spine does hurt. Discs in particular hurt quite a bit. But I've even done patients without anesthesia in their discs. So it's an individual choice. It's something we discuss. We're honest about it. And it's an option. If you want anesthesia, it is an option. We can arrange for it. It just takes extra scheduling. There's some more limitations. You know, you can't eat after midnight and getting tired or getting hungry rather towards the end of the day. There's some downsides discussion stuff with anesthesia. There's risks, there's cardiac risks that have to be taken into account as well. But it is something we offer here, and if needed, we can arrange for that. Maybe the last question is last thing I'd like to. A lot of people are very terrified when we start talking about bone marrow stem cells. Very terrified of that bone marrow procedure. That is the least of the painful things that we do. Done properly with proper anesthetic, proper ultrasound or X-ray guidance, it's really not a painful procedure. I've had mine taken out. I can attest to the fact that it is very tolerable. I had no nitrous oxide or anything with it other than 1% lidocaine, and would do it again tomorrow if it needed to be done. Really, honestly, no more invasive, no more painful for me than a blood draw. And I would say at least 80% of my patients would agree with that statement. Maybe slightly more painful than a blood draw, but if you had to have it done again, it's really not a traumatic procedure.
Yeah, on average, I think my patients tell me it's like on a scale of 1 to 10, it ranges at about a 3 to maybe a 5. That's usually like the worst that we'd hear of it. For the most part, it's actually like Dr. Nabity said, it's very well tolerated. We do this under image guidance, so there's no fishing around in there. We go directly to the site that we need to go. We anesthetize the area really, really well, so it makes the procedure very tolerable when we do the procedure.
Well, I think this was great. I'm sorry we didn't have time to get to everybody's questions. We love to set you up for a consultation if you would like to further evaluate your condition individually. We do telemedicine visits, so it can be done just like this over the internet. Our phone number hopefully is on here somewhere. You can certainly find it, but it's 248-216-1008. And I'd like to take everybody on a quick tour of our new facility. We just moved into a new facility 2 months ago. We've fully settled in, and we now have a lot more capacity than we did at our previous facility. We can do everything under one roof. We don't have to take stuff to outside surgery centers or outside facilities to get things done, which really helps with our scheduling and convenience for getting the procedures done. So,
yep. And then I just put on the chat box there our phone number. Again, that's 248-216-1008. And yeah, we'd love to talk to you. I know everyone, this is a very new field. I know a lot of people are very interested in it. And I do understand that some physicians are not, I guess, in tune with how regenerative medicine or what regenerative medicine is. So it'll be a great opportunity to kind of discuss your case individually. All right, so enjoy the tour, and I'll talk to you later.
All right, everybody. Well, thanks, John. So this is our new facility. In the hallway behind me here is this is our patient evaluation hallway. So we'll just walk down here, and we have 7 exam rooms. They all, for the most part, look the same, but get a ultrasound. We can do your your physical exam, the history. Everything will take place in one of these exam rooms. If you're coming in for a procedure, we'll do our preoperative discussions in these rooms. If you're doing a PRP, we do the blood draw in these rooms. And then after your blood's drawn, our technician would take it down the hall and into the lab. So you can see in the lab, first step here is the blood goes in, or bone marrow goes into our centrifuge. That spins at very high rates, 42 to 4,400 RPMs. That separates the blood and bone marrow and isolates the middle layer, which we then take to the vented hood in a sterile fashion, are able to separate the products we want from the products we don't want. We do a double spin technique, so then the products go back into the centrifuge, spun a second time to further isolate the layers and the products that we're not interested in from the stuff that we know is most beneficial. A second time back under the vented hood, and then the third step and the step that really separates our clinic and clinics like ours that do a validation, we do a cell analysis, so we can tell you exactly how many platelets you have, how many total nucleated cells you have, to know that we're using the right dose. Then once we have the right, and we know we have the right dose in our syringe, we take the product with us into the operating rooms. And we have 2 operating rooms. One that is set up for fluoroscopic guided procedures. So this machine here is a fluoroscope. This is what is an X-ray machine. It allows us to see through your skin into deep structures, in particular when we're doing spines, or if we're doing any intraosseous injections, we're actually injecting into the bones. This is the machine that we use. The monitor's there in the corner, and it's basically you take a shot with the X-ray and you look where your needle is, and you make a slight movement, take another shot with the X-ray, so on and so forth. This here is that nitrous oxide machine we talked about that we use for anesthesia, the laughing gas, our suction machines, our cardiac monitors, and then this machine we have set, or this room we have set up for our ultrasound guided procedures. So that's our ultrasound machine. No radiation with ultrasound. That's one of the big differences. But ultrasound really good for soft tissue structures like tendons, ligaments, muscles, cartilage, but not very good for deep structures. Not good for injecting into bone or for doing things like discs. That's where the X-ray machine would come in. After your procedure, we typically recover in the operating rooms. And then once you're recovered from your procedure, depending on what's being injected, we either walk or we use a wheelchair. And then we have our exit with a dedicated door for patients to come and quickly come pick you up. We do recommend most people have a driver so that you don't have to worry about driving home if you're in any kind of pain. And then lastly, show you our front lobby and our front entrance. And our lovely receptionist is giving the tour, so she's not sitting behind the desk. But Ravina will be here in her smiling face to greet you should you wish to come in. I really appreciate everybody taking the time to check in with us today. We'll try to start doing these at least once a month. Kind of a mixture of dedicated procedures, maybe some case evaluations where we'll really dive deep into a patient we treated, or show you some images, show you some before and afters, spines, disc herniations, cartilage in knees, stuff like that. I think would be really interesting, and then always have some questions and answers at the end. I doubt we'll ever have time to get to everybody, so please do feel free to call us. Happy to do, like we said, telemedicine visits or in-person live. Thank you again for taking the time. Hopefully we'll see you all soon.